be talking on refractory angina. I think the definitions have already been dealt with, so I might as well skip it. And prevalence, as has been shown, is about 3.2% in the Clarify registry, having class 3 to class 4 angina, and 5 to 10% having stable coronary artery disease. It has profound effects on the quality of life. And the 1-year mortality in these patients is quite high, 3.9%, and 9-year mortality is 28.4%. So much higher than RCTs of PCI and CABT. Now, this has also been discussed, multivariate predictors of mortality being age, diabetes, anginal class CKD, and LV dysfunction. Now, incomplete revascularization can be seen in 43.3% of patients undergoing PCI and 36.8% of patients undergoing CABT. And therefore, there is an unmet need for additional medical therapies to alleviate the symptoms and to improve the quality of life. This is a 77-year-old lady who came to us who had a CABG. And you can see that there was a total occlusion of the LAD and there was a tight stenosis of the diagonal. On the other side, you can see an OM occluded, 2 OMs, and the RCA was totally occluded. Yeah, that is RCA graft. You can see that the distally the flow is not too good, and that is a graft to the OM that is patent. And in fact, this the OM injection I had done 2 months ago, and that time it was ulcerated plaque and it called for a bypass, angioplasty, but she came 2 months later and you can see it is totally occluded. Now it is a contraindication for surgery, but she's having a refractory angina. And the Lima graft was totally occluded. There's absolutely no trace of the Lima. So we just opened the diagonal for whatever it is worth, and the angina has been 50% relieved. Now, what are the possible combinations of anti-anginal medications that one can use? You can see, we all know the anti-anginal drugs, beta blockers, ivabradine, nitrates, nicorandil, the dihydropyridine calcium channel blockers, trimetazidine, deltaesem, and verapamil. Now, the essential, the theory is that you can combine beta blocker with dihydropyridine calcium blockers. You can combine ivabradine with nitrates. So, do not combine drugs which reduce the heart rate. So, that's the theory. And you can combine ranolazine with beta blockers, and trimetazidine can be combined with ivabradine. So these are the second line agents which are available. And emerging drugs are available, but really they are not much RCTs. Now, ranolazine is, has been FDA approved since 2005. It inhibits the late phase of inward sodium channel, and it also reduces intracellular calcium influx and reduces oxygen consumption. And this is tested in the RIVER PCI trial, and this is done in a group of patients who had incomplete revascularization after PCI. Now, there were around 15 countries participating in this and 245 sites, and patients were randomized to ranolazine and placebo who had a history of angina and incomplete revascularization. So it was around 1,300 in each arm, and the primary endpoint was ischemia-driven revascularization and ischemia-driven hospitalization, and event-driven minimum of 1 year follow-up. And you can see that at a median follow-up of 643 days, the primary endpoint was slightly less in the ranolazine arms, 26%, whereas the placebo arm, it was 28%. And the hazard ratio was not much, 0.95, and not significant. Therefore, despite incomplete revascularization following PCI, there was no incremental benefit in angina or quality of life measures by adding ranolazine in this angiographically identified population. But there was sustained improvement in both the arms, but the admissions were not reduced by the ranolazine group. So I think certain side effects which I did not know until I read this for this presentation of ranolazine. One, it can produce thrombocytopenia, skeletal myopathies, and because it is metabolized in the liver, it can have other complications, and it should not be used in dialyzed patients and with creatinine clearance less than 30, and it can prolong the QT as well, and therefore QT, serum creatinine, blood urea nitrogen, and urine output needs to be monitored. That's very important. Now, nicorandil. That's again a second line agent. It's a nitrate derivative of nicotinamide. It's an adenosine-sensitive K channel opener. It's a nitric oxide donor. Therefore, it gives both a balanced coronary vasodilatation and peripheral vasodilatation. It has been put to test in the Iona study, which was presented long ago in the AHA 2001. And the advantage is it doesn't produce any coronary steel. And this, as with the Iono, tested it against placebo, and you can see that if you look at the proportion who were event-free, you can find CHD, death, non-fatal MI, and unplanned hospitalization were much lesser in the nicorandil group. So that is little surprising. But actually, the CHD, death, and non-fatal MI, when tested, were the same. It was only the unplanned hospitalization which was reduced by nicorandil. Now, if you take all CV events, proportion event-free was lesser in nicorandil. However, there was no impact on mortality, and hard endpoints were the same. But this is the first large-scale clinical trial to report on the effects of a specific anti-anginal medication on clinical outcome. Now, the ivabradine drug, all of us know, it inhibits the funny current in the SA node, and this was tested in the Signified trial, and it looked at the quality of life. Ivabradine, reduces the heart rate. And what they found, physical limitation, there was not much difference, a P of 0.085, but anginal frequency was significantly reduced, disease perception was reduced, anginal stability was reduced, treatment satisfaction was pretty good, and the health status was also good, all favoring ivabradine. But in a meta-analysis of ivabradine, you can see that there was no difference in the cardiovascular death, all-cause mortality, hospital admission, and coronary revascularization. And one disturbing side effect with ivabradine is force genes. You get these bright shadows in your vision, and atrial fibrillation in 6.3%, which is a very high percentage. So that is the other drawback of ivabradine. So when to exhibit ivabradine? Chronic coronary artery disease with sinus rhythm, so not in AFib, only in sinus rhythm when there is a contraindication for beta blockers like bronchial asthma or peripheral artery disease, uncontrolled anginal symptoms, and heart rate in excess of 60 beats per minute despite beta blockers. So there also we can use ivabradine. Now, Fesudil is not available in India. I don't know whether anybody has used it. It's a Rho kinase inhibitor, enhanced vasorelaxation, and it also reduces vascular inflammation and is useful in enhanced vasoactive state. Now, these are the adapted recommendations for anti-anginal therapy by ESC. Now, what I'd like to tell from the first line treatment is indicated with beta blockers or calcium channel blockers. That is the first line. Now, if anginal symptoms are not successfully controlled with beta blocker or a CCB, then you can add a beta blocker plus a dihydropyridine calcium channel blocker. Now, initial first line treatment with a combination of beta blocker and dihydropyridine can also be considered, but it's a class 2A recommendation. And long-acting nitrates is a second line option. And also we have to give a nitrate-free interval. Now, the second line agents, like whatever which I have mentioned now, they're all class 2A indications when patients continue to have angina. And as I mentioned earlier, with low heart rate and low blood pressure, we can use ranolazine or trimetazidine. And nitrates are not recommended in hypertrophic cardiomyopathy or co-administration with phosphodiesterase inhibitors. Now, we have a lot of these vascular endothelial growth factors. They're all upcoming, and the future has to be decided. The VEGF-A, the VEGF-D, it stimulates angiogenesis and lymphogenesis as well. When this has a reduced risk of pericardial effusion. Stem cell therapy, regenerative medicine is a vision of the future. Regeneration of myocardial tissue and new blood vessels, bone marrow derived progenital cells. It has got mixed results. The problem with these cells are that it do not transform into myocytes, but they have paracrine effects. And it is in phase 3. 2 trials have been completed, intramyocardial delivery of these cells. The clinical evidence is still uncertain. Personalized tailored treatment is a need of the day. A single anti-anginal agent, no single anti-anginal agent is more effective than another one. Number of agents have been studied, and no anti-anginal agent improves ischemia by improving cardiovascular death or MI, except beta blockers post-MI. Anti-anginal therapy is to be considered as symptom limiting and not outcome improving. And pain relieving, I think the opiates and all, it cannot be used because it only reduces the perception of pain in the frontal cortex. So how to go about in refractory angina? When somebody is referred for refractory angina, review the perform the imaging. And if more than 10% of the LV myocardium or more than 3 segments are involved, then I think you have to review or perform the invasive angiogram. If there is something which is treatable, please go ahead and treat it. If it is a CTO, you can refer to a CTO specialist or a colleague. And otherwise, you have to go for tailored medical therapy. And if less than 10% of the myocardium, I think optimize the medications. So refractory angina has a significant impact on quality of life and outcomes, evaluation of the underlying cause. And a personalized approach is the best way to go. Thank you for your kind attention.